Welcome to another episode of Everything Digital Health. I'm Marcus Bohr. I'm a GP and a software developer and a health tech specialist. And today I've got Sam from MedConfidential with me again. He was with us a couple of weeks back to talk about the Federated Data Platform, a sort of intro guide to that. But today we're going to talk about the NHS Single Patient Record, which is something that's kind of popped onto the scene in the last year or so. It's been heavily trailed since about October last year as part of the new Labour government's plan for the NHS and how they're going to solve all our problems. Now, there is numerous ways to sort of discuss this. I think there are potential benefits to having a single patient record in terms of the convenience for patients and the idea that there'd be more of your record in one place so that numerous different contributors to your healthcare could get hold of that record. But there are also risks. They include things like the privacy risk. How much of your medical record are you happy for the government to have complete access to? And there is also the risk of the entire program failing because it's been tried before. So, Sam, that's the kind of intro of what it is and what's been planned. So from your point of view, what are you hearing? What do you think the SPR will turn out to be in reality?
The single patient record is the big idea underlying all of Wes Streeting's headlines. If you want to give GLP-1 drugs to people on universal credit so they stop being blockers on the economy, use Wes Streeting's term, you need a record to write that to, and you need to check that they're not going to have adverse events. And every GP in the country will go, that doesn't sound like what a GP is going to do. But the big plan from Our Future Health, who are heavily written into the 10-year plan, is like, well, they'd quite happily do that. And so, the single patient record will be all of your medical notes, all of your diagnoses from everywhere across the NHS in a single record, visible wherever the NHS logo is seen. You walk into a pharmacy, they will be able to do whatever it is that pharmacy can do operating at the top of their practice. And they will be able to do that basically on anybody who walks in off the street. All of the reasons that you're on your existing medications, all of the things you've told your doctor, going back basically, if you're under about 45, going back to birth, because that's how long GPs have been digitized, all of those notes will be sitting there to be read. And this is sold as you don't have to repeat yourself.
Yeah.
But I'm not entirely sure that your GP or a doctor you're talking to knowing everything you've ever told a doctor. Don't forget, these new consultations will be recorded and they'll be transcribed and they'll be summarized. So there'll be all of that text. But what it'll be is they'll use AIs. They will have an AI summarize why the AI thinks you are in front of that doctor, and the doctor will just read that before talking to you. And I'm pretty sure that will be so unreliable that your doctor will ask you, okay, why do you think you're here? Maybe they already know.
Well, there's another aspect to this as well, which is repetition is not necessarily the bad thing that politicians make out that it is. I think there is a certain amount of unnecessary repetition. Imagine if you're receiving cancer care in a number of different places and you've got to bring everyone up to speed to what you actually have had done rather than what the systems think you've had done. That's dangerous gaps in knowledge, and that kind of repetition where the patient is the interoperability, that's dangerous, and we don't want to get that out. But quite a lot of the time when we are asking questions to a patient, or we're actually doing that to generate some rapport, because it's about a conversation about your condition and about you and about what can be done about it, and sometimes confirming how are things now. Has anything changed since we last saw you? Because of course your no repetition medical record might be up to date till the last time you saw a doctor 2 weeks ago. But since then, the symptoms have got massively worse or massively better. So a lot of that repetition stuff is actually part of drawing out really why are you here and how bad is it? How much is it affecting you? And also, nobody wants to just be treated by somebody who's read the computer, turns around and starts treating you. They actually need you to feel human. And some of that is going, oh, right. So, yeah. So you've had this for a long time, have you? You don't want the patient to turn around and say, well, yes, it says in the record that I've had it for 18 months. The part of me asking that question is to generate some kind of a communication with the patient. And all GPs are taught to do this. So there is a certain amount of repetition that is necessary and required to make it feel like a human interaction. And the other thing is, very occasionally, that's how we find an inconsistency. So it's not unheard of for you to go into a GP surgery and we get the record up and we start talking to you, and I say, oh, so I see you've had gout for 10 years, and they go, no, I haven't got gout. And you say, well, oh, right, it says here you're on allopurinol for gout, and they say, well, I have got a similar name to another patient in this practice. And it's like, oh. And if we try and engineer a world in which you never have to repeat yourself, then we are 100% relying on absolutely positive patient identification. Because sometimes the repetition is how we pick up the fact that we got the wrong patient or the wrong notes or both. And that is an important safety mechanism. So I'm very skeptical of trying to propagandize that no repetition is actually the desired state, because it's not. And anyone who thinks it is needs to go to medical school, and then they can come back and tell me what is and isn't the end desired state for a single patient record.
Yeah, but the people who are designing this didn't go to medical school, and they assumed that the technology is perfect. If you read the 10-year plan, it basically assumes that the technologies that they want to roll out, voice recognition, AI diagnosis replacing a GP, etc., are all perfect. There were never any failure modes. But they also assume that no technology will exist that they haven't thought of. So either it works and it's perfect, or nothing is going to change. So the 10-year plan is very much a wish list of multiple people writing the things that they think should happen. And when you put, largely hospitals and tech companies in charge of writing a document, it's a document that sounds really good for hospitals and tech companies. But one of the things that the 10-year plan is looking to do is to sort of move away from a GP practice to something more akin to a GP neighborhood health center, which isn't run by GPs, it's run by your local hospital, and which has about the same footprint as your other job center. There'll be about the same number of neighborhood health centers in the country as there are job centers. Maybe a bit more, maybe a bit less, depending on your area, but that's basically the footprint. And you won't go to see a GP in the way you would normally do, in the name of abolishing the 8 a.m. rush and making access more equitable. You'll be able to use a chatbot at any point, day or night, to talk about your health. And if the chatbot thinks you need to see a doctor, well, it will work that out for you. And if the chatbot doesn't think you need to see a doctor, it will go, why don't you go talk to the pharmacist? Or why don't you, go to sleep? Because, some mental health crises at 4 a.m. in the morning are real mental health crises, and that's the only time you can deal with it. And some of them are go to sleep and see if you're still worried about it in 5 hours, and you wake up and you're feeling refreshed and the problem's gone away. So, there are lots of things to work out there. But the assumption of the 10-year plan is that the single patient record will make all of the data available to the AIs, and the AIs and chatbots will basically do the right diagnosis for you, which is not a human process. It's a very much a mechanical process instituted by the Secretary of State, making political decisions for political reasons. Wes Streeting will make one set of decisions, Matt Hancock will make a different set of decisions, Nigel Farage would make a different set of decisions, but they are the ones who do it because the chatbot will operate under the direction of the Secretary of State, because he's the one who will own your central patient record.
You bring us on to quite an interesting area there, which is when you have got a medical record that is essentially being looked after by a government, then you have to design that medical record as though the next government is going to be a totalitarian fascist state. It doesn't matter how good you think the government is now, but you've always got to defend yourself against the bad government that could be next. Because if you've got a medical record that's rich enough, you can tell everything about that person. You know their sexual orientation, you know their gender orientation, you know things that they have engaged in, such as drug taking practices. You have a very, very detailed insight into that person. It's very personal and it's very private. And government of today might be quite liberal and might say, yeah, that's all fine. But you only need the next government to be a fascist government who decide, well, we're gonna start trawling medical records to see who might be an illegal immigrant. And we think we've got some flags which possibly suggest, I think you mentioned it on the last call, sexual dissatisfaction might be associated with essentially loveless marriages that are, sham marriages to do with immigration. But they might not be. But you decide that flag is something you're interested in. You decide that you want to get people's home address and send that to the border force. And we know that happened. So that there's I'll link to the Independent story about that. But at least it's like 10 years ago, before any kind of single patient record existed, we know that there was a memorandum of understanding between NHS Digital and the Home Office, allowing them to share information from medical records to allow border enforcement. Now, as much as it's necessary to have border controls because we're a sovereign country, it is not appropriate to misuse medical records for that purpose. And we as clinicians are the ones who have to stand in the way. We are the ones who swore the Hippocratic Oath or the Declaration of Geneva. We are the ones who record that information in people's notes. And if we don't stand up, no one else will, because the governments and the civil service, that they are just happy to have a functioning government system. They just want the data so it can flow around government anywhere it wants to. So how willing are we? How happy are we with the idea of a single patient record being owned by the Department of Health and Social Care, which is just a branch of the government?
Your GP practice owns your medical record, but you can walk in and talk to your doctor. You might have to stay just sitting in reception for half an hour until you get to see one, but you can go see your doctor and you can talk to the person responsible. You can talk to the practice manager. As GP practices get closed, and the plan for the 10-year plan is proposing to close most GP practices, because going from the current footprint up to the scale of a job centre, what will happen is one practice will win and the others will all die. You will lose that ability. And when it's a single patient record, you can't go and talk to the people who manage the records. You cannot go and talk to the data controller unless you go and stay just sitting in Wes Streeting's office. Now, today, as you have a GP practice, they own your medical record. Then they restrict how it's used and they go through processes, and there's a bit of shouting about whether or not this is legitimate or not. But generally, there is a process where if a purpose is legitimate, it can be used. If a patient is willing for it to be used, it can be used. If promises are seen to be kept, it can be used. But where somebody goes like, well, we've got this piece of paper and we use it for whatever we want. How about you give us all the data? The practices go, is that what you really told people? Like Biobank. They gave a bunch of data to insurers and said, this is what our users wanted us to do. And the GPs were like, are you sure? And Biobank are like, yes, our agreement says that we can do this. Our patient groups are happy, our board are happy. And, a year on, it turns out the patient groups were not happy. Turns out the board seemed not to have been happy. And now they've banned that use. And the only people going, we should actually read what is going on here, were the GPs. And the University of Oxford and Biobank were like, that's just wrong. Nobody should have any oversight of what we do, which is a very Boris Johnson worldview. Like, politicians can do whatever it is they want, and Boris doesn't want anybody to have any say in any of it, because that's the culture that the single patient record will go into. It'll be sitting in government, and it can happen. It is going away from a GP practice that you can go and talk to a department that you can't.
Yeah.
And the reason that they want it is not because they want to make your GP's life easier. It may help in certain situations, but if you walk into a pharmacy, they can already look at your GP record. GP Connect as a system has been abused for this purpose for years. But it's like, you can't control the GPs. The GPs have a relationship to their patients. They expect to go and see their patients. And if something happens to the data that patients don't like, they can go stage a sit-in in reception. And breaking that link is one of the things the single patient record is for.
Very important point, in that most people have no need to know, but your GP record is looked after by your GP since the very start of digital records. Those records, they started off as Lloyd George envelopes in your GP practice, and then it got turned into digital records. But those digital records, the data controller in law is still your GP. And what's being proposed with the single patient record is that data controller won't be your GP. It'll essentially be the Secretary of State for Health, which changes the accountability. As you say, it's much easier to go and stage a sit-in and get to see your own GP to complain about a misuse of your record than it is to stage a sit-in and get to see the Secretary of State for Health. But it also raises, let's talk about a sort of failure mode of big records. I mean, everybody's assuming that if you have a single patient record, that it tends towards the truth, because you've got constant curation of this perfect record. And that's actually not true in practice, because what tends to happen, the more contributors to a record, the harder it is to maintain what you'd call like a record keeping discipline, because they're not your employees. When you're a GP surgery, you can go and speak to your staff and say, the record you made about that consultation. I mean, I've had this actually happen to me as a locum, where one of the partners has asked me to record more information, or in fact, I've also had it where they've come and said that was a very well recorded consultation, because they have internal medical record keeping discipline that they can enforce, because they run the show and they're the data controller. That's not going to be the case in a single patient record. So I could imagine it's going to end up a bit spammy almost. There's going to be all kinds of garbage that's been recorded, a lot of defensive medicine. So, for example, if you see a out of hours GP, the notifications that we get from out of hours GPs are about 4 pages of absolute bollocks that says the patient did not have bleeding, the patient was breathing, that, and they might be going for some, ingrown toenail problem, and that will be one line at the very end. But we have to read through all this guff that was about them protecting, covering their asses and saying we did all these checks on the patient to make sure they weren't dead before we saw them for their toenail. All that's going to be in the single patient record. So actually mining out the vital critical bits is going to get harder. And so you can get to this point where, in theory, you have access to all the data, but it's equivalent to somebody handing you a ream of A4 printed paper, some of which is just advertising guff, and some of which is incredibly valuable patient information. And they will hand you that block of paper 5 minutes before you see the patient and say, here, doctor, familiarize yourself with this patient. Obviously, if there's anything in there that you miss, and then you subsequently mistreat the patient, you're going to jail. We'll strike you off and we'll take your house, because triple jeopardy for medical professionals for making a mistake, because the information was in there, doctor. I think you'll find when we take you to court, it was in there, and you'll say, yeah, but it was in there diluted amongst a whole load of hogwash, and they'll say, doesn't matter, doctor, you failed in your duty. So single patient record sounds great if it's a curated, snappy, sort of synopsis of exactly what you need to know. But what I've seen in practice of poorly curated records is that it tends towards just a blancmange of uninterpretable garbage about the patient, hidden among which is just like a couple of useful things. That's
Sounds
the worry.
entirely like a ministerial briefing. And the thing is, your GP won't exist anymore, so it will be the Secretary of State that you sue. You won't sue Marcus Bohr GP practice down the road. You'll go sue the department. And at which point you get much more covering of arses. And then you get even more stupidity in the process, because everybody will want to make sure that that doesn't happen to them. And the whole thing will stop. But there's some assumption in some conversations that, GPs will just keep using TPP and EMIS of their existing suppliers. Well,
at some point that will make no sense
if they pay for it. But West Street said you must check the single patient records. It will have stuff in it that's not in another record. Okay. But then why do GP practices maintain their own records? Because if they're mandated to check this blancmange, why would they want to keep their own copy and manage their own copy, especially when the neighborhood health center is run by your local hospital? It is not run by GPs, because these records will not be held for the purpose of the GPs, they'll be held for the purpose of the state. And it will, the proposal for the neighborhood health centers is everything is recorded, so doctors can see transcripts of what patients said, then patients can see transcripts of what patients said, which is useful, and they get summarized. But it's like, how do you know the summary is right? Well, we have to keep the transcript. How do you know the transcript is right? Well, we have to keep all the recordings. And so over time, you will have every conversation you've ever had with a doctor recorded. And, as to, middle-aged, middle-class white guys, it's probably not that much, but it's a case of, for, the canonical example is the teenage girl talking to her doctor. Do you really want that to be recorded and fed back and read by AIs basically indefinitely into the future, as long as you assume the NHS is going to exist?
Well, that's it. I think there's a threat model there, as you say, for people who might consider themselves to be an at-risk population, either through ethnicity, their background, their sexual orientation, anything like that. They might be less keen to consult with these services and actually may avoid having medical care because they're worried about, as you say, the voice transcripts being kept, the voice recordings being kept, and everything being potentially accessible by the government of the day. And I mean, let's not forget, it's a little early in the conversation to be bringing in the Nazis, but one of the reasons why it was so easy for the Nazis to round up all the Jews in the Netherlands was because the Netherlands had excellent record keeping of everybody's ethnicity and religion, and so having great records can backfire. And that doesn't mean we don't want to have good quality medical records that are accessible by everybody. It's a question of, do you want those to be owned and operated by the government? That's the question.
And there are lots of directions to take that. So the 10-year plan says that the single patient record will start rolling out in maternity hospitals for newborns to do newborn monitoring. Babies keep dying unnecessarily. We should stop that happening. The single patient record should be there. And one of the things that will go into that record for prevention purposes, whole genome sequencing. Every baby will get sequenced at birth, and it will be put in a single patient record, because everybody knows you start with the children. And that seems like something that is defensible. Now, the genetics people will tell you that out of 100,000 people, that might help 4 of them. And the NHS will tell you that if it would help those 4, then a baby born yesterday would have that same sequencing. You don't need to do it for all of them. But yeah, people want the data. But once this data is sitting in the single patient record, you can use it for data mining.
Yeah.
Over time, like, is it people with these particular genes that have this particular condition? The genetic basis of prevention is what the 10-year plan calls it. But all of that data is sitting there. Everything that you will have ever told your doctor, going back to like the early 90s,
Yeah.
can be put in and correlated. And yeah, in the same way that you don't just get ads on Facebook for things you've looked at, you get things for people that people like you have looked at. That same data mining will start to be used to look at what conditions people like you might have and to do prevention. And prevention is important, but prevention being done in discussion with your GP is prevention that's basically centered in you and somebody who has a continuing relationship with you. Prevention done at a national scale is what is it we can convince Treasury is worth the money or politically necessary, and it doesn't involve you at all. There was the example that we usually use is the COVID-19 app that pinged you if you've been somewhere. The
Yeah.
Scottish app had a bunch of features, and if you turned any of them on or off, like that bit didn't work, but you could still have the basic functionality.
Yeah.
The English app took a different approach, which was unless you gave it all of the permissions, unless you gave it everything it wanted, it refused to work.
Yeah. We're creating,
And
I
those
think,
are
in
political decisions.
a single patient record creates the single largest sort of cybersecurity honeypot in the world, because, as you say, it brings together all this medical data, very identifiable. Any medical record is fully identifiable, even if it's been anonymized, even if it's been pseudonymized, because you can always work out who it is from collateral information. I think we've talked about this before. So it's a massive, it signals to the entire world, attack us to try and get this information. It's a honeypot. And I'm not convinced that the NHS, and even with its clever tech partners, is up to the job of preventing all cybersecurity attacks. Because, I mean, you only have to go back as far as 8 years ago, WannaCry. We had the biggest NHS, one of the biggest cyber attacks in the world, went through the NHS like a dose of salts, because everybody's on the same operating system, and there's actually a very low level of technical capability within the NHS. We tend to outsource everything. So we outsource cybersecurity, we outsource our systems, we outsource our networks, we outsource our email. So there's nobody inside the NHS who actually knows how to do any of this stuff. And I remember working with people who were freelancing to try and fix WannaCry at the time when it all hit. And that will happen again, but this time, instead of shutting down hospitals, they'll have taken your entire medical record out of the SPR as well.
So if you read the 10-year plan, it doesn't talk about where the single patient record will be stored. The delivery chapter is curiously missing, maybe because there's going to be no delivery. But
yeah,
the week before the 10-year plan came out, Department of Health was putting out very nice press releases about what wonderful things would be in it. But according to the 10-year plan, the single patient record will be what's used for the maternity dashboards, the maternity monitoring, and the whole genome sequencing for babies. According to the press release submitted a week earlier, that's all going to be done in the Federated Data Platform. So, according to the government's own press release, the people who will be doing the cybersecurity here are Palantir. And, Palantir, I'm sure if they were here, would say that they are quite happy to put the same cybersecurity into the NHS as they put into their spooky and military customers. And, it's probably true. But that's where the data will be sitting. And it will be sitting in standard formats, so able to be used and available via APIs. And that starts to build up a bunch of interesting questions, because what else will that data be used for? Palantir is a very opinionated company. They pick sides, and the world will change.
Yeah.
What happens if, the US invades Canada? Palantir has picked sides. America first.
Yeah. If they're
Britain
delivering
may,
healthcare services in Canada, which side? Yeah, they'll withdraw from that side. Yeah,
do they
exactly.
betray their customers? What happens when, Donald Trump decides to invade, Northern Ireland? They can look after themselves, but, Scotland.
Yeah, exactly. When you're dealing with, dodgy customers, as you say, you've got to have a big picture geopolitical risk spectrum out there and say, yeah, we've decided to use a supplier, but they have picked sides in the geopolitical stage, and if we fall out with the wrong countries, we could end up without our records, either non-functioning records, or worse, those records being actually used against us. As
or even just the tool, like, it looks like Cancer 360 is down today. Well, yes, that's a breach of our uptime guarantees. We're looking into it. And suddenly you don't do cancer treatment. And I'm pretty sure that their UK staff wouldn't do that. Their US staff can walk into the UK office the same as the US staff can. But probably an extreme scenario, and there are contract breaches, and the NHS would probably have to figure something out. But it is a case of what is the 10-year plan. Try and get this somewhat back on track. The 10-year plan is largely on prevention, largely via automated means. If you've ever told your doctor that you possibly same-sex attraction, that they may have noted that, and suddenly you're in that bucket, and you will always be picked up by those AIs, even if that was 40 years ago and you have never thought about it since. What you tell your doctor gets recorded, and it's important for your health that that's true. But things that no longer matter. Why were you on those antidepressants 30 years ago? Well, you were going through a divorce and you haven't thought about your husband for 25 years because he died shortly afterwards. Well, it was stressful at the time. It'll all be there, and it's all just sitting there, and the AI doesn't necessarily know the difference. And how you clean that up, it's something a human would instinctively do. But the single patient record is about having everything available for everybody. And if there was being a informed, broad discussion with the profession about how this would work, like, where is this actually going to be, and what is it going to be used for? In the context of, like, how is it going to work with GP? How is it going to work with hospitals? How is it going to work with, mRNA vaccines and blood tests for cancer? There are lots of moving parts. You could have that conversation, but it's not being there. It's like Department of Health has decided this is the future, and we are going to do it this way because AI is the future. And
let's take it in a slightly different direction then, just to sort of explore this area, in that we're talking about the future, and we're assuming some of our risk modeling here, or our kind of threat modeling, is about assuming it all works. But we've heard this in the past, haven't we? I mean, there have been attempts in the past to create a single NHS patient record. And in fact, it's interesting, there's a Tony Blair thread that runs all through this, because the Tony Blair Institute has been heavily involved in influencing the current 10-year plan. Back in the Tony Blair government era, so going back to the late 90s, early 2000s, it was that government that started the National Project for IT, which is now renowned and almost used as a watchword for burning public money with almost no benefit. I think when audits were done, they spent £12.5 billion, and only something like 2% of the initial aims were achieved. And out of NPFIT, we probably got NHS spine services and NHS mail were some of the things that we could say did arrive. But the big picture stuff, which was the single patient record, that never happened. And part of the issue there is it's not, if you look at this as an engineering task and say, can we store the amount of patient data needed? Well, yes, of course you can. But how do we interact with it? Well, GPs have got systems that are suited to general practice with which they interact with a patient record. Hospital doctors have different systems because they have got different specialties. An anaesthetist is doing a very different job to an ophthalmologist. And so they will have different interfaces. Having been a user of medical interfaces for my entire life, really, I can say that most of those interfaces are pretty bad. But what would be even worse would be a single patient record interface. And so there's nothing really in the functional requirements, which I'm just looking at, I'll include that in the show notes. The functional requirements of the SPR doesn't really make it clear that the record will need to be viewed in different ways by different staff groups, and that will be fundamental to delivering a functioning piece of kit. It can't make medical record interfaces even worse, because if it does, that will break the NHS.
So, like, the RFI was as much a fishing expedition as it was anything else. They had to go and talk to the market so they can say they've talked to the market. And clearly, if you read the government press release, they're just going to do it in Palantir. And Palantir, quite happily we're quite happily given an anaesthetist one interface, and an ophthalmologist another, and a physio another, and a GP another, and they'll all write to our common data model. And, it's not necessarily wrong to say that you can do that. Like, is it actually practical in terms of, does it serve the front line, the people who are actively seeing patients? Well, who the hell knows? But it will be something that, like, they can say works in the same way that, National Program of IT said this will work and said it'd be wonderful. It's the same people 20 years on, literally the same people. And the big thing that the Blair Institute doesn't like about the Federated Data Platform is that they gave it to Palantir, not Oracle. And Oracle give a lot of money to the Tony Blair Institute.
Yes, there's been rumors in the rumor mill about Oracle's involvement in, sniffing around the SPR. I hear that there's some kind of coalition, Oracle, Palantir working together is now the way that they're styling it. That potentially that will be the partnership that delivers the single patient record. Oracle for, to give it a veneer of trustability, and Palantir because they're already in and we've already paid them.
I think Palantir will be involved because a bunch of the dashboards and all the data will have to flow. But if you end up hiring somebody who's not already doing that, Oracle, give a lot of money to the Blair Institute, would like some payback for that. And the Blair Institute's answer is, it's in one of their reports, like, you should give Oracle a big contract. But for the single patient record, EPP, EMIS already largely have it. They already can look into hospital systems and see various bits of information that's made available. You can expand that a bit. There are areas in the country that already have something like a single patient record. Wales has something like a single patient record. They use Patients Know Best, and they glue everything together and show it in a shiny app. And it even works in the NHS app. And it works in the NHS app if you're in England and your hospital is a PKB user. You can pull in your GP record and pull everything else and show it to you. But it's not showing you as a single source of this is the truth. Like, these are what the different care providers are saying. Where there is a conflict there, where a GP says you need to be referred to a hospital for this treatment, and the hospital says our waiting list is too long, go away. It doesn't, cover that up. It shows that that's where the discrepancy is and gives patients information.
I think the idea
the hospital is hospital is running the single patient record, and the plan for the neighborhood health centers is for the hospital to run the single patient record, that notion of a waiting list, that notion of referral disappears because you're being bounced around inside an organization. You're
Yeah.
not getting referred from your GP to the hospital and on the hospital waiting list. You're effectively being referred from the hospital to the hospital, and you disappear out of the waiting list. How do
I
you
think
avoid the referral waiting list? You abolish referrals, not the waiting.
the the idea, which is mentioned quite a few times in the SPR spec document, is this idea of a single version of the truth. And I think that that's a very naive concept. That's not something that a clinical practitioner of medicine would necessarily recognize if they've seen how, every patient record you have is to some extent a different facet of that patient viewed at the time they were seen by the doctor that saw them. There isn't necessarily truth in anybody. I think there are a few things that you can reduce to a single version of the truth. So if you have a very clearly diagnosed allergy, we can code that in your record, and it probably is a single version of the truth for what you're actually allergic to. GP systems already have that. That's not adding a new feature. And as you say, that's available via the summary care record and GP Connect and various other sort of windows into the GP system. But for a lot of things like medical and diagnosis history, there is not really a single version of the truth. There is always differences of opinion around what exactly the diagnosis is in a single patient, especially if they have a complicated condition or a rare condition, or something that for which there's different ways of treating it. Or also the patients change over time, so your signs and symptoms when you're first seen might be different to what 5 years later. Now, does that mean the diagnosis changed, or did you have the same diagnosis all the time and just the way it was expressing itself was different? It's the real world is a lot more messy than this tech utopia that we're being sold.
Yeah, and this is government. They assume, HMRC assumes that you are telling the truth on your tax returns, and all the facts necessary on the tax returns are there. And when it comes to money and numbers, there is an objective truth that you can pull out of bank detail, and people should put it on their tax returns. Some people may even do so. But even with DWP, they can basically go, if you don't say everything, we will charge you with fraud and put you in jail. And maybe you can argue that's complete, but you can see the mess that they've made of disability payments, that doesn't necessarily always work. But in the NHS context, there is no obligation. You as a GP will often ask your patients, how much do you smoke? How much? And those numbers may bear some resemblance to reality. How much do you drink? People are terrible at it. And the solution in the 10-year plan is that anybody who has a wearable, like smartwatch, or even just carries a phone around you which counts your number of steps, that data should be available to the single patient record, where the Palantir AIs can work out, did you get drunk last night? And they're going to be very, very good at it, the same way they can pull out almost anything from the data feed.
Well, let's have a look at use case number 2, blood pressure, from the SPR document, because actually that's a very interesting one and links in with what you're saying about the GP gradually being abolished, because actually patients must fight back against this and prevent that from happening, because your GP is not acting as a person who forces a diagnosis on you. They're acting as your medical advocate, in the same way as a lawyer is your legal advocate and your accountant is your taxation and financial advocate. You're paying them to be on your side and to guide you through the process. So as a GP, we do not blindly just implement the nice guidance on blood pressure, because we also take into account what the patient actually wants to do about their blood pressure. So they might have treatable blood pressure, but they've decided that they would like to do some lifestyle options for the first 6 months. We might go with that. Or we might advise them, no, look, there is a risk to you. of not treating this blood pressure. It's super high. It needs treating. So we're all the time, we're coming from the patient's point of view and what's best for the patient, taking into account their wishes. Algorithms, AIs, and government sort of population health management doesn't care about your particular circumstances. Whereas your GP is acting as your medical advocate. And so just reading the use case number 2, it says that the patient will upload all their blood pressure readings and then get told, essentially, according to the algorithms, you should be on treatment. And I don't think anyone clinical would look at that and think, oh yeah, that's just as simple as they've written it there, because there's so much human interaction that goes on around that. Sometimes we do a one reading and it's a bit high, and you think, I'll do that again, and you do it again and it's come down a bit, and you think, actually, look, I don't want to throw some drugs at this patient based on a couple of high readings. You start doing maybe some more regular monitoring and that sort of thing. But we aren't blindly implementing the NICE guidance. And I think anyone who did would be conducting an experiment at population scale about, for the first time, fully applying the NICE guidance, because we always take into account the patient's unique combination of circumstances. For example, if they're already on 2 drugs for blood pressure, do we bring in a third one, or do we replace something, or do we send them for specialist treatment, or do we investigate them for a pheochromocytoma? All of those things are in the NICE guidance, but it's so much about being a medical advocate for the patient. And I think there's a lot of naivety thinking that these can be reduced down to algorithms delivered at national scale and it'll all be fine. Because I think there will be deaths, there will be morbidity, which is not death, but ill health caused by extra unnecessary care. I think it's a really terrifying future to actually think about as a patient and as a clinician.
They don't care about an individual patient in the same way the Department of Work and Pensions does not care about an individual universal credit claimant. Like, that's not what they do. They cannot see you as a human. Whereas the GP is like, there's somebody walking in, I presume they're human. And if they're on 4 legs, they might have brought their dog. But it's a case of this will all be done via algorithms. And how those algorithms are designed will not be something that's about a doctor talking to their patient. In the same way that the way Universal Credit does, or GDP Universal Credit does their health assessments, is not in line with NHS guidance. And you get some patient who's sort of given a particular diagnosis, like, that's really expensive to treat. Like, look at the waiting list for ADHD. Like, a doctor could do that analysis, but like, well, we don't like that. Let's kick them off to another process, and that other process never completes. And what you end up with is just a health system that's kind of a health system, but it's also about managing the political demands. And at which point public confidence in it will fall apart, because they cannot assume that what's being written in the record is for the patient's interest. And if you're recording everything, people will just not tell doctors things. Because, they know there are microphones in the walls and everything gets, like, even if you say it once, it's there permanently. And that's a terrible dystopia. And
what will happen there is that the people with the means to do so will start moving out of the NHS and seeking private healthcare. And actually then privacy will be a luxury item that you pay for. If you want a GP who uses paper records and never puts anything into a computer, I can see there being an actual business model right there to say, I'm a private GP who never puts anything into a computer. Nothing is on the internet. We cannot get hacked. I just use a little notebook per patient. And that's as good as it gets. But you get healthcare, but no one can see it from the government.
So the Department of Health's answer to that is, okay, we can ban that. And there is a proposal kicking around that private GPs should be able to read and write the existing GP record, let alone the single patient record. And in practice, you'd be able to do that. So the things you want recorded are recorded, so the NHS can pay for the drugs. But anything you don't want recorded, you get to pay for and avoid. You can't do that at the local neighborhood health center because, everything is recorded. But like down the street, there'll be somebody else. And that is the vision of the most Andrew Lansley privatized healthcare you can think of. Like, basic services and everything else goes another way. And maybe that's the world Wes Streeting wants, because it's the world he's moving towards.
It
And I
does
can
feel as
see
though the
it.
Tories load the gun and Labour pull the trigger. That seems to have happened several times in history. That happened with a National Project for IT and PFI hospitals, for example. PFI is such a Tory policy enacted by Labour. Just for the last few minutes, I wonder if we could talk. We've done a lot of knocking and kicking around of this idea, and I think there are lots of gaping holes in this idea yet to be clarified. But if you were going to do a single patient record and make it work and make it good, how would we do it? There's some missed opportunities here, is what I'm saying.
So that's the wrong question, because the single patient record is a technology and it is a set of decisions. But like, what are the decisions? What is the healthcare we want? And one of the things buried in the 10-year plan is that, there'll be things about blood tests. Blood tests for cancer isn't in the 10-year plan. Like, they're starting to work. There are lots of trials. And the trials aren't like, does the blood test work to discover cancer? The answer to that is yes, it does. The trial is like, can we expand it? Where does it work in practice for populations? How do you integrate that into the NHS? You've got the mRNA cancer vaccines, which are also starting to work. And the trials there are, which cancers does it work better or worse for? And does it work after 5 years is a question we cannot currently answer, because the trials have been running for 3 years. Like, if the trials had failed, we would have known that by now. But we don't know they've succeeded because it takes longer than that. So you will end up relatively quickly getting completely new forms of treatment. And the next general election will be in 2029. Maybe before, but 2029. And by then, current science means it is entirely feasible that if your cat gets cancer, you take your cat to the vet, they biopsy the tumor, they biopsy the cat. You take your cat home. A couple of days later, you take your cat back to the vet. It'll complain like hell. You'll give it an injection of an mRNA vaccine for that particular cat and that particular cancer, and it will effectively cure some types of cancer in your cat.
Mm-hmm.
And my cat is somewhere around here, and like a few £1,000, like, it's worth keeping the cat around. It is politically untenable for you to be able to do that with your cat at the vet, and you not be able to do that with your loved one on the NHS.
Yeah,
same
exactly.
science, same technology, same probable companies behind it. If you're taking your cat to the vet, something's gone really wrong with GP, but things might go really wrong with GPs. But that is the world we are likely to be in by the end of this parliament.
Yeah,
And
that's
the
hugely
10-year
interesting.
plan has lots of wonderful things in it, like, and some, like, life sciences will cure everything, but the NHS won't change. Like, who is going to be your advocate for your health, and who is going to go to bat for you in the way that your GP currently does? Because your neighborhood health center is never going to do that, because they work for the local hospital. You might get the odd consultant who do it in the same way that every GP will basically help out their patients, because that's what they feel that they went into medicine for. And, how do you navigate this new system?
You need a medical
Because
advocate,
when
don't
that
you?
will, you need a medical advocate. And, is it going to be whatever the NHS chatbot is? And if you don't want to use the NHS chatbot, you can go privately for another one. And that, like, single patient record, will be available to private providers. You may decide that you don't want to use the NHS chatbot, you use the slightly RC chatbot that goes to bat for you. And quite frankly, somebody would, one of the charities may do that for, here is the evidence to DWP from your medical history of why you should win your PEP claim. And you just end up with chatbots arguing with chatbots. The assumption of Wes Streeting and his 10-year plan authors are that the chatbots will only ever work for the government. And I don't think that is reality, largely because anybody can build these things. And you will end up with an NHS that turns into a pie fight, and patients will be left in the middle, working out, well, what's the actual best treatment for me? And government will say, well, we think the best treatment for people like you is that you should at least die cheaply. And there are various governments that might turn around and say that, and the NHS goes, that's not how we work here. But the NHS, as you abolish NHS England and put the Secretary of State in personal charge of everything, Wes Streeting simultaneously thinks he'll be Secretary of State forever and also wants Keir Starmer's job. And the next, a future Secretary of State for Health could end up with the level of interest in patients that Andrew Lansley had, which was none at all.
Well, I think that's a great line to end on. Having spent a lot of my career working through the Lansley reforms, I have no particular affection for the guy. Thank you again for being on. It's been really interesting discussion. I think we're starting to unpick some of the ground truths around, what is the SPR, what is the Federated Data Platform, how linked are they? And I think we will continue to discover more, because this is still it's still evolving in a very active way. We don't necessarily have the facts about what anything will be, currently, etc. But I think it's kind of nice to focus on, some of the potential gains and future benefits, as you did with the future of cancer care, which, cancer could be a massively reduced burden if mRNA vaccines deliver their promise. So that's an interesting one. But yeah, thank you very much for being on, and I'm sure we'll do another episode quite soon. Thanks. Bye, Sam.
Thank you. Bye-bye.